Hi guys, in the last class we learned in detail about the importance of eustachian tube function for the proper functioning of the mid-layer and how the various disorders in mid-layer are related to the eustachian tube blockage causing the negative mid-layer pressure. We also learned in detail about the various conditions such as acute otitis media with effusion, acute necrotizing otitis media, then bullous meningitis. All those conditions were discussed in detail. Today we will be learning about chronic otitis media, where the duration of mid-layer disease is for more than 3 months, and this chronic otitis media can be further divided as chronic otitis media, mucosal disease, squamous cell disease, and healed chronic otitis media. The healed chronic otitis media includes both dermatosclerosis as well as healed perforation. Today we will be starting with the mucosal disease or chronic otitis media tubotympanic disease, which was an earlier terminology, and this condition is the most commonly seen clinical condition in ENT. And what is happening here, there is a permanent abnormality in the pars tensa which is exposing the mucosa of the mid-layer, and that is resulting in recurrent infections. Okay, now there is a permanent abnormality in the pars tensa of the mid-layer without involvement of tympanic annulus for it to be called as a mucosal disease, because if there is involvement of tympanic annulus, that can result in a marginal perforation, and marginal perforation can indeed predispose to the formation of cholesteatoma. Okay, so for the purpose of understanding these perforations and for classifying the perforations, a division of the tympanic membrane into 4 quadrants was proposed. And how is it being done? Through the handle of malleus, a line is drawn, and another line is drawn perpendicular to that. Okay, like that the tympanic membrane pars tensa is divided into 4 unequal quadrants, and these quadrants, if you are seeing a perforation, you can describe it accordingly. And another thing that you have to know is that a perforation which is confined to one quadrant is what is known as a small central perforation. This is a small central perforation. Okay, that is involving only one quadrant. So this is a small central perforation in the postero-superior quadrant. Okay, now if the perforation involves 2 quadrants like this without involvement of tympanic annulus, this is what is called as a medium sized perforation. Okay, medium sized perforation, and that is involving the postero superior and postero inferior quadrant. If it involves 3 quadrants like this, then it is what is called as a large central perforation. Okay, now the largest large central perforation with just not involvement of tympanic annulus and whole of the pars tensa being involved, that is what is called as a subtotal perforation. It will be like this. Okay, so that is a subtotal perforation. So these are the various types of tympanic membrane pars tensa perforations that you have to know. Okay, this is how you describe the perforation when you are asked to describe the mid-layer abnormality. Now these are some real life pictures which I took from the endoscope, and what do you see here? This is a case of a subtotal perforation. In a subtotal perforation, only the tympanic annulus will be present over the pars tensa. Rest of the pars tensa will be gone due to the perforation. So this is a case of subtotal perforation, and you can see clearly the various mid-layer structures. Right, in this picture, let's revise some of the mid-layer anatomy that we have already learned. What are the things that you see here? This is the ear ossicle. Which ear ossicle do you see here? You can see the handle of malleus here, and this is the ingus lenticular process. You have the stapes here. This is the round window niche that you have here. Okay, and this is the lateral process of ingus that you see here. Okay, and so which side is this? How will you identify the side of the tympanic membrane? First of all, you have to look whether there are any erosicles seen, and if the handle of malleus is seen, you can look at the direction of the handle of malleus. If it is shifted to the left side, then it is the left tympanic membrane. Left 11 o'clock position, everything is the left tympanic membrane. Okay, now what do you see here? You can see that handle of malleus is towards the right here, and the ingudocipitral joint is seen here, and this is the round window niche area. So this is the right TM, right tympanic membrane is seen here. Okay, so this is how you identify the structures in the midlear, and in this picture you can see a bit more of the structures, right? What is that? You can see the pyramid over here. Okay, it is coming from the posterior wall, right? And from the pyramid arises the stapedius tendon, and the stapedius tendon goes on to attach to the, yes, it goes on to attach to the neck of the stapes. Okay, so you have the stapes head here, to which the lenticular process of ingus is getting attached. This is the handle of malleus. This is the lenticular process. Okay, so here the handle of malleus is in the 1 o'clock position. 1 o'clock position means it is the right. Okay, the handle of malleus is curved towards the right, so it is the right tympanic membrane. Okay, this is the round window. You have the stapes here. Okay, so that's how you identify the various structures in the midlear. Now, what is this? This is the healed otitis media. I told you there are two types of healed otitis media, right? One thing is healed perforation that you see here. What are the features of a healed perforation? It will have a hypermobile segment of the tympanic membrane, that is indicative of a healed perforation. That area will appear like a perforation initially, and then when you notice carefully, you will be see that it is being closed by a membrane, and it is so thin that it will be hypermobile. And why is it so thin? Because there is no fibrous layer. Fibrous layer is the thing which gives that support to the tympanic membrane. So that is absent in a healed perforation. Okay, and here you can see the tympanosclerotic patch. This is the tympanosclerotic patch. Okay, what is happening here? Here there is calcification in the fibrous layer. Okay, that is what is happening, and that results in myringosclerosis. Myringosclerosis is when tympanosclerosis is seen within the tympanic membrane. Tympanosclerosis can also be seen within the midlear cavity, and it can result in fixation of the various ossicles. Okay, so that's about the types of chronic otitis media. Mucosal disease. Okay, we learned about the various types of perforation in chronic otitis media, and it could be active or inactive, but depending whether there is discharge coming out of the ear, and it also could be divided according to the size of the perforation and where the perforation is present. Okay, all these things can help in classifying the chronic otitis media mucosal disease. Okay, healed perforation is a type of healed otitis media along with tympanosclerosis, and chronic otitis media squamosal disease is another topic in itself that will be dealt with shortly after completing this mucosal disease. Now, how will you manage a case of chronic otitis media mucosal disease? If he is coming in the active stage with ear discharge, first of all you will have to clean the exonotic canal. Okay, the whole pus has to be cleaned. For that, what do? You do a ear toileting. It could be done by suction clearance. Okay, suction clearance can be done, and even dry mopping also may be done if the suction cleaner is not available, but ideally it should be a suction clearance, and along with irrigation has to be done. Dry ear soon, and only after having a dry ear for 6 weeks we can contemplate on repair of the tympanic membrane or laryngoplasty. Okay, laryngoplasty. Now, when will you decide you have to go for a laryngoplasty and not just wait for the perforation to close on itself? When are you going to do that? What you are going to do is, we are going to assess if the discharge is for more than 3 months. Okay, only if the discharge is for more than 3 months we can contemplate on doing a surgery, because most of the time the perforation heals on itself after a case of acute otitis media, and if it is a traumatic perforation, healing by itself is the rule. Okay, so we have to wait for at least 3 months. Even after 3 months, if it is not healing, there is no chance that it is going to heal. Okay, how is it healing? I told you it is healing by 2 layers. The epithelial layer will be there and the inner mucosal layer is there. Okay, so if it does not heal, what is happening is that the epithelial layer goes on to meet the mucosal layer, and there is an epithelialization occurring in the perforation edges. Okay, so in that case, when you are repairing the tympanic membrane, you have to remove a thin rim of perforation. Okay, only then you can put the graft inside and make the tympanic membrane repair done. Okay, so it is very important that you remove the thin rim of perforation, because there is epithelialization taking place. Just like when you put a piercing over the ear lobule, after some time you will be having a hole which will not close, right? The reason is because of the epithelialization occurring. If it is mucosa in that area, they will heal, they will come together. Okay, similarly in this case also, the perforation, if it has to come together, there should be no epithelialization over the edges. Okay, so what you do is, you do a laryngoplasty, or is it tympanoplasty that you are going to do? Actually it is tympanoplasty we are doing. Laryngoplasty you can do, but you have to be sure that there is no ossicular abnormality. Okay, you have to be sure there is no ossicular abnormality, and the patient is having a good cochlear reserve, the mid-ear ventilation is normal, there is adequate aeration of the mid-ear. Okay, all these things have to be assessed, okay, before contemplating on doing a laryngoplasty without ossicular repair. What will happen if you are not doing that? If I am not doing that and going to repair the perforation alone, if the perforation was about 40-45 decibel, after the surgery it will become 54 decibel. Why? Because it was through the perforation the sound waves were getting into the oval window and stimulating it directly. When you are doing this, when you are doing a laryngoplasty, that will shield the sound wave from reaching the oval window and round window, and because of that there will be a worsening of hearing happening. Only the bone conduction will be taking place. Okay, so that is why the hearing loss is about 55 decibel in that case. Okay, so always you have to assess if there is any ossicular abnormality. How will you assess? One thing you can do a Puritan audiogram, and you will be getting a rough idea about the hearing loss the patient is having. Of course, that is one thing. The second thing what you can do is a patch test. Patch test. How will you do a patch test? For that, you use a cigarette paper and close that perforation and check whether the patient's hearing is improving after repair of the tympanic membrane. Okay, that is, if after putting a cigarette paper and when you do a Puritan audiogram, if the hearing has improved, then you will do a laryngoplasty. If the hearing is worsening, then you go for a tympanoplasty. Okay, And what else you can do? You can do an autoendoscopy and examination under microscopy. Okay, this examination under microscopy can be done while you are doing the suction clearance and ear toileting itself. Okay, that will ensure a better ear toileting when you are doing it under microscope. And of course you can send the pus for culture and sensitivity when the patient's ear is active. Okay, and you will be giving topical antibiotics. It could be a ciprofloxacin dexamethasone combination or ofloxacin dexamethasone combination. Usually pus for culture and sensitivity reveals mixed aerobes and anaerobes. Okay, Pseudomonas is the most common culprit, and of course acetic acid ear drops also can be given. And antibiotics, the systemic antibiotics ciprofloxacin 500 mg BD for 1 week duration will be adequate in most cases. And you have to give topical antibiotics along with antihistamines, decongestants for the perforation and the discharge to come down. Okay, the discharge coming from the perforation, if it has to come down and the ear has to become dry, you will have to give systemic as well as topical antibiotics. Okay, and after the ear becomes dry, you have to wait for 6 weeks before contemplating a surgery. Okay, now how will you do the surgery? For doing the surgery, you have to put an incision, right? And the most commonly put incision is the post-oral William-Weil's incision. Okay, I have showed the pictures of Weidling so that you remember the name of the incision, that is William-Weil's. It was named after William Weil. Okay, the incision's name is Weil's post-oral incision. Okay, you will be putting like this. In case of children, it is put a little horizontally like this because of the risk of injury to the facial nerve, because in the area of mastoid the incision is actually put from the area of the attachment of pinna, and from there it goes down up to the mastoid. Here you have the mastoid tip. Okay, what is the problem with children? The facial nerve is exiting more peripherally in this area, okay, in the mastoid tip area. So when you are putting the incision itself, there is high chance of injury. So in children you are putting an incision in a horizontal manner. Okay, and after putting the William-Weil's incision, what you are doing is you will reach up to the periosteum by dissection, and then you will push the pinna forwards and then enter the posterior canal. Okay, so while entering the posterior canal, in order to avoid injury, first of all we will be putting a cotton inside. Okay, because when you are putting incision, the incision should be confined to the posterior canal wall. It should not go and touch the anterior canal wall. To prevent that, you will put a cotton ball inside. Okay, so after putting an incision over the posterior canal wall, you will be putting a ribbon gauze, and then you will be pulling the pinna forward so as to visualize the perforation as well as the mid-layer. Okay, now, so this is the most commonly put incision, and this approach is the most commonly done because you will get a good access to the mid-layer with this approach. Okay, and for a case of extensive cholesteatoma, when you are doing a mastoid surgery also, this is the preferred incision. And another advantage is that when you are putting this incision, you can harvest the temporalis fascia graft, and it is harvested from the same incision itself. Okay, and what are the advantages of using this temporalis fascia graft? It is the same thickness as of the tympanic membrane, that is of 0.1 mm thickness. And what are the other advantages? It is having a low BMR. It is an autograft. Okay, it is an autograft, and it is resistant to infection. There is less chance of infection, and it is less chance of getting extruded out. It usually heals well. Okay, and you can take as much as temporalis fascia as you want. Okay, because above the temporal line it can go up to here. Okay, so you can take as much the size as you want. Only thing is you will have to extend the incision further if you want a bigger graft. Okay, so that is the advantage of the temporal fascia graft. It is a thin graft of only 0.1 mm thickness, which is the same thickness as the tympanic membrane. It is having less BMR. It is an autograft, and yes, it could be harvested from the same incision. There is less chance of getting extruded out, less chance of infection. Okay, this is a common question that is asked, why temporal fascia graft is preferred while doing a meringoplasty. Okay, now what is the other type of incision that you see here? This is the Rosen's endomeatal incision. Okay, you will be putting an incision like this in the 6 o'clock and the 12 o'clock position. You will put vertical incisions and then a curvilinear incision connecting the two, and this is done for wide canal. When you have a wide canal, it is easy to do an endomeatal surgery. Okay, endomeatal approach will be enough. And when you have a small perforation and the perforation is posterior, also it is more preferred. Okay, now what do you see here? This is a Lambert's endoral incision. Okay, Lambert's endoral incision, you will be putting an incision through the incisura terminalis like this. Okay, along with that another incision is put within, that is a Lambert 1 part, that is from the 6 o'clock to 12 o'clock a curvilinear incision is put. This is the Lambert 2. Lambert 2 is through the incisura terminalis. I already told you why this incision is preferred, because it is going through an area where there is no cartilage, so there is no risk of perichondritis. Okay, no cartilage here, so no perichondritis. Okay, so these are the 3 different types of incisions used. Okay, this is the Rosen's, this is the Lambert, and this is the Weil's incision. Okay, but Weil's incision is the most commonly used incision, and Rosen's is used more for otosclerosis surgery, that is stepidotomy. When you are doing, you use the Rosen's incision. Okay, now coming to the various types of tympanoplasty. I was talking about meringoplasty here, right? How you are using the various types of graft to repair the tympanic membrane. Temporal fascia is the most common graft, I told you. And before going to the types of tympanoplasty, what are the other grafts that are used? You can use a tragal perichondrium, or even the tragus itself, the cartilage can be used, or a congal cartilage can be used. Okay, so the various grafts that are used are congal cartilage, tragal cartilage, tragal perichondrium. Then you can use fascia lata. Okay, fascia lata may be used. Even dura is used. Okay, it is not an autograft, it will be the preserved dura, that may be used, and vein graft may be used. Okay, saphenous vein is the common vein used. Okay, so these are the various types of graft which are used for repairing the perforation. And when there is a ossicular abnormality suspected, in that case you will have to do a tympanoplasty, right? In meringoplasty, we are not at all inspecting the mid-layer and looking for any perforation. If it is we are not looking for if there is any ossicular abnormality, if it is present or not. Okay,